Today's topic is hypertension. Hypertension is very important cardiovascular disease, and I will use 3 lecture hours to complete this lecture. Today I will do the first part of the lecture, and soon I will upload the second part of the lecture to the Moodle. And third part of the lecture I would like to do in a lecture theatre once the university is reopened. During this lecture, I am going to discuss about the introduction to the hypertension and the presentation of hypertension to the primary care and measurement of blood pressure and other parameters, and when to manage the person with hypertension and how to manage the person with hypertension and update of recent evidence of hypertension. Hypertension is not a disease. Though some consider it as a disease, it is really a risk factor, and it is important because it is a modifiable risk factor. Lowering blood pressure decreases risk of stroke, coronary event, cardiac failure, and renal impairment. Hypertension is undiagnosed and undertreated in most of the time in most of the countries. 1.13 billion people worldwide have high blood pressure. 1 in 4 men and 1 in 5 women had hypertension in 2015. Less than 1 in 5 people with hypertension have the problem under control. In 2000, 972 million people had high blood pressure. That time, it was projected that this number will increase by 60% by 2025. 10% of the global healthcare expenditure used to treat the high blood pressure. An annual worldwide cost for high blood pressure management is $370 billion. By 2025, it is estimated that there will be 1.6 billion people with high blood pressure. Hypertension leads to an increased risk of death from stroke and heart disease. When your blood pressure rising from 120 to 80 to 140 to 90, this risk is multiplied by 2. When your blood pressure rising from 120 to 80 to 180 by 110, this risk is multiplied by 8 times. If you don't treat the high blood pressure, it can lead to heart failure, left ventricular hypertrophy, myocardial infarction, coronary heart disease, hypertensive encephalopathy, cerebral hemorrhage, preeclampsia and eclampsia, stroke, chronic kidney failure, blindness, aortic aneurysm, and gangrene of lower extremities. Prevalence and incidence. More than 25% of world adult population is already hypertensive. It accounts for 10.4 million deaths per year globally. By 2025, 1.56 million people will be having high blood pressure. It is seen in high prevalence in African Americans. 5% of pediatric population having high blood pressure, and this prevalence increases with age. There is a strong positive relationship between blood pressure and risk of cardiovascular disease events. Blood pressure trend shows clear shift of highest blood pressure from high income countries to low and middle income region. High income countries, the number is 349 million. When you compare with the low middle income countries, the hypertensive number is 1.04 billion. So there is a very high number of high blood pressure patients in low and middle income countries. How about situation in Sri Lanka? In Sri Lanka, prevalence of hypertension is 18.8% in male and 19.3% in female. Only 22% of diagnosed hypertensive are adequately controlled. Only 6 to 15% of diagnosed hypertensive are adequately evaluated for risk factors for cardiovascular disease and target organ damage. What are the determinants of high blood pressure? Determinants of blood pressure: blood volume, vascular resistance to the pressure, and heart stroke volume. So blood pressure is equal to cardiac output into systemic vascular resistance. Cardiac output depend on the heart rate and stroke volume. So if changing of these factors will change the blood pressure. Vascular resistance depend on vascular viscosity of blood and width of vessels. It is due to constriction or dilatation. So the regulation of blood pressure, there are a few mechanisms. One is a sympathetic nervous system, which is respond immediately through the baroreceptor activation. It sends the signal to vasomotor center in the brain, and then the sympathetic nervous system innervated tissue contract or dilate and regulate the blood pressure. Another important mechanism is renin-angiotensin mechanism. It retains, when activated, it retains the sodium and water to increase blood volume, constrict blood vessels, increase and aldosterone. That mechanism is seen in the kidney, which respond to renin-angiotensin system. Aldosterone and antidiuretic hormone are sent out as needed and control the blood pressure. So the homeostatic control of blood pressure dependent short term mainly the sympathetic nervous system causing vasoconstriction and dilatation. Long term it is mainly controlled by renin-angiotensin aldosterone mechanism. When you consider the renin-angiotensin cascade which you learn in physiology, when there is a decrease in arterial pressure, renin secrete and renin substrate convert into angiotensin 1 by renin. Angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme inhibitor, and angiotensin 2 has vasoconstrictor effect as well as renal retention of salt and water. These two contribute to elevation of the blood pressure. What are the etiologies for high blood pressure? 90% of hypertension is essential or idiopathic, where you don't find the cause. 10% of hypertension is due to secondary hypertension, where you identify the cause. What are the causes for secondary hypertension? Common causes are renal parenchyma disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, drugs or alcohol related. Uncommon causes of secondary hypertension are pheochromocytoma or paragangliomas, Cushing syndrome, hyperthyroidism, aortic coarctation, primary hyperparathyroidism, congenital adrenal hyperplasia, mineralocorticoid excess syndrome, other than primary aldosteronism, acromegaly. What are the risk factors for high blood pressure? Overweight, excess sodium consumption, physical inactivity, stress, low potassium, magnesium, and calcium intake, excess alcohol consumption. How do they present to primary healthcare practitioner? Usually they are asymptomatic, and when you check the blood pressure, you identify the high blood pressure. Sometimes you may be identify this asymptomatic hypertension during the routine screening procedures. Sometimes they can present with a headache or visual disturbance, and when they develop the target organ damage due to the symptoms of target organ damage, they can present. They, they can develop the left ventricular hypertrophy and heart failure, so they can present with the heart failure symptoms. They can present the TIO stroke symptoms. They can present with the myocardial infarction or angina. They can present with the renal impairment symptom. They can present with the peripheral vascular disease or visual disturbances. What is this picture? You can identify this is Candy City. This is just closer to Queen's Hotel. You can see a lot of people in this town at this moment. So when you compare the past and today, you can see the difference. What does it show? With the rapid development, urbanization, and increased population, so people under stress. So stress is one of the main contributor for high blood pressure. And you know now Sri Lanka and the globally the population aging is increased. So aging population also risk factor for high blood pressure. When the age increases, high blood pressure also increase accordingly. When you have the long-term high blood pressure, it will lead to damage to the kidney and end up with the end-stage renal failure. So having said that, hypertension is important medical problem and it is the commonest medical problem globally. So when you are diagnosing high blood pressure person, it is very important to measure blood pressure accurately. Why accurate measurement of blood pressure important? This is the very latest the information I gathered from 2020 International Society of Hypertension guideline, which was released on 6th of this month. Accordingly, they have recommended how to measure the blood pressure. The blood pressure, the measurement room should be quiet room, and it should be compatible with the temperature. No smoking, coffee, exercise for 30 minutes before coming to check the blood pressure, empty bladder, relax for 3 to 5 minutes, and take 3 measurements at 1 minute intervals. Use the average of the last 2 measurements as a blood pressure reading of the person. And person should sit back supported, no talking during and between measurements. When you put the blood pressure cup, it has to be appropriate. Arm bare, the arm should bare forearm and arm, and resting mid arm at resting and the mid arm at the level of heart. And here you can see feet flat on foot floor, and you can use the sphygmomanometer or validated electronic upper arm cuff to measure the blood pressure. So, as I said earlier, it has to be in a quiet room. Appropriate size cup mean the bladder inside the cup should encircle 80% of the arm. Midline of the cup over the arterial pulsation, and cups should apply 2 centimeters above the antecubital fossa. When you are measuring the blood pressure, feel radial pulse first. Note level of the pressure at which pulse disappears and reappear with inflation and deflation of the cup. Use the stethoscope, place bell over the brachial artery, take the reading. Bladder deflate should be no more than 2 millimeter per pulse beat. Record systolic blood pressure, that is a phase 1 cortisol sound, and the diastolic blood pressure, that is a phase 5 cortisol sound to nearest 2 millimeter mercury. Repeat the reading after cup bladder deflated for at least 30 seconds. Is accurate blood pressure measurement important? Elevated blood pressure is a common finding and asymptomatic till target organ damage. Elevated blood pressure confers substantial risk of cardiovascular disease. Incidence of cardiovascular event in people with high blood pressure can be reduced with drug treatment. Detecting and treating high blood pressure before onset of target organ damage is cost effective. So it is very important to accurately measure the blood pressure. Underestimation of blood pressure denies large number of people access to potentially life-saving and morbidity preventing therapy. So if you don't diagnose a high blood pressure patient properly, so it is bad for the patient and he will end up with target organ damage. Overestimation of blood pressure substantially increases number of people with inappropriate diagnostic labels and therapy. So if you overdiagnose person, it is a lifelong diagnosis and medication. Diagnosing and initiation treatment of hypertension can cause psychological harm to patient also. So as a doctor, you have to accurately measure the blood pressure because that is the only way to diagnose high blood pressure correctly. Should we recommend home self measurement of blood pressure? There is a condition called white coat hypertension. This white coat effect can raise blood pressure in excess of 20 by 10 millimeter mercury up to 40% of the patient. So consider home self-measurement of blood pressure to avoid overdiagnosis due to white coat hypertension. How about recommendation of ambulatory blood pressure measurement? Consider ambulatory blood pressure measurement for evaluation of the patient with suspected white coat hypertension, apparent drug resistance, episodic hypertension, hypertensive symptoms from antihypertensive treatment. American Society of Hypertension strategy for use of ambulatory blood pressure measurement and decision of treatment. Persistent elevated clinic blood pressure person, you apply the ambulatory blood pressure monitoring and see whether first check whether there's a target organ damage. If target organ damage, patient is having need to get the treatment. If no target organ damage, you can do the home blood pressure, check the home blood pressure values. If high, treat with the antihypertensive. If home blood pressure measurement is normal, then you apply 24-hour blood pressure monitoring. If it is high, treat as a hypertensive. If 24-hour ambulatory blood pressure measurement normal, then no need to start the antihypertensive. Continue to monitor in clinic and home and review the patient regularly. So then we have to understand how to define the high blood pressure. This is very important thing because by that we decide the treatment of the patient. And important to note is there are so many recommendation, guidelines and studies done on high blood pressure, and according to the JNC 7 recommendation which was done 2003. Since then there were several other recommendation. JNC 8 recommendation 2014. In 2017-18, American Heart Association and American College of Cardiologists recommend the guidelines, and most recent is a 2020 International Society of Hypertension guideline. So now we had to follow International Society hypertension guideline because that is the latest. According to this latest guideline, which was published about 2-3 days ago, category of blood pressure in adult is as follows. Blood pressure is considered as normal when the systolic blood pressure is less than 130 mm mercury and diastolic less than 85 mm mercury. Blood pressure is considered as a high normal blood pressure when the systolic blood pressure is 130 to 139 and or diastolic 85 to 89 mm mercury. So hypertension is when the blood pressure is above 140/90. There are two grades of hypertension according to the values. Grade 1 hypertension is blood pressure 140 to 159 and diastole 190 to 99. Grade 2 hypertension is when systole more than 160 and no diastole more than 100. So this is the most latest recommendation. Before that, in 2017, ACC and American Heart Association published a guideline. According to that, this is how hypertension was classified. Normal when the blood pressure is less than 130 and 80. Elevated when blood pressure is 120 to 129 and diastole is less than 80. Stage 1 and 2 hypertension. Stage 1 is when the blood pressure is 130 to 139 or diastole 80 to 89. Stage 2 is when the blood pressure more than 140 or more than 90. To further complicate the matter, this is the European Society of Hypertension Guideline 2018. So here you can see it is different from the previous two guidelines. So according to the 2018 ESC guidelines, optimal blood pressure is when the blood pressure is less than systole less than 120, diastole less than 80, normal, high normal according to these values. Then hypertension is graded into three stages: grade 1, 2, 3, and they have mentioned about another category that is a isolated systolic hypertension when the systolic blood pressure is more than 140, diastole is less than 90. So this is the JNC, that's Joint National Committee Guideline 2003. It was 7 guideline. JNC 8 guideline was published in 2014. There are no much differences. According to that, this is how hypertension was categorized. So you can understand various recommendation and guidelines give different values. So most recent value recommendation is International Society of Hypertension Guideline, which was published on 6th of May this year. That is the latest guideline. So remember those values. According to blood pressure values, when you check the blood pressure at your clinic and the home, when your blood pressure is normal at clinic and normal at home, you are normal tensive or you don't have high blood pressure. If your blood pressure at clinic is high, at home blood pressure was high, then you are having sustained high blood pressure. When you check the blood pressure at clinic, no high blood pressure, but when you check at home, there is a high blood pressure. Then it is called as a mass hypertension. And when you check the blood pressure at clinic is high, home blood pressure is normal, then you call it as white coat hypertension. Now I am going to show 4 clinical scenarios. Just go through those scenarios and later you decide which person is benefited by treating with antihypertensive treatment. Case 1. Mr. A, 55 years of old accountant, non-smoker, no family history of premature atherosclerotic diseases, feels well, take no regular medication. Reason for visit is routine annual checkup. Clinical findings: blood pressure 160/100, right arm sitting position, otherwise normal. Question is, how to treat his blood pressure? Scenario 2. Mrs. B, 45 years, fitness instructor, non-smoker, no family history of ischemic heart disease, use healthy diet and active lifestyle. Reason for visit is persistently high blood pressure, average 150/95 for 6-month time. Clinical findings: fasting blood sugar 6, cholesterol 4.4, HDL 0.85, LDL 2.51. Clinical examination: UFR ECG normal. Clinical question is, should we initiate antihypertensive treatment for this lady? Case number 3. Mr. C, 45 years old, sales executive, smoker, family history of premature MI, trying diet and activity modification. Reason for visit is persistent average home blood pressure 150/95 for 6 months. Clinical findings: obese, BMI 29, fasting blood sugar 8, total cholesterol 7, HDL 1.85. Clinical examination: UFR ECG normal. Question is, should we initiate antihypertensive treatment for this person? Scenario 4. Mr. D, 68 years, retired, non-hypertensive and diabetic, well controlled, on metformin, AC inhibitors and aspirin. He is on supplement vitamins, calcium, magnesium tablet and fish oil. Reason for visit: want reassurance that he is doing everything he can to stay healthy. Clinical finding: blood pressure 160/100, HbA1c is 6.8. Question is, what treatment are likely to reduce morbidity and mortality in patients with high blood pressure like Mr. D? So now question comes, how do you decide initiation of treatment for a patient with hypertension? Decision about management of patient with high blood pressure shouldn't be made based on their blood pressure level alone, but also on the presence of other risk factors, target organ damage, concomitant diseases like diabetic, cardiovascular, and renal diseases should be considered. So I said about the risk factors. What are the risk factors for hypertension? Major risk factors are smoking, dyslipidemia, diabetes mellitus, age more than 60 years, sex, men and postmenopausal women, family history of cardiovascular disease, women less than 65 years or men less than 55 years. So these are the major risk factors you have to consider when you are risk stratification of the patient with hypertension. What are the target organ damage you have to consider in a patient with hypertension? Look for heart disease, evidence of left ventricular hypertrophy, angina or previous MI, prior coronary revascularization, heart failure. Look for stroke or TIA, nephropathy, peripheral artery disease, retinopathy. Look for these risk factors when you are assessing a patient with high blood pressure. According to NICE guideline, that is a NICE guideline is a UK the main health guidelines body, suggests carrying out the cardiovascular risk assessment in all hypertensive. Not only NICE, all other international guidelines recommend to assess the 10-year cardiovascular risk. So when you are, how do you assess this 10-year cardiovascular risk? There are different tools to assess the 10-year cardiovascular risk. Examples are Framingham risk equation, WHO cardiovascular risk prediction chart, cardiovascular disease life expectation models, the Dundee coronary heart disease, the ProCam risk function, The British Regional Heart Study Risk Function. There are different bodies publish different way of 10-year cardiovascular risk assessment, but basically the principle is the same. So this is the WHO ISH cardiovascular risk prediction chart you can use when you are assessing 10-year cardiovascular risk of the patient with hypertension. So why you have to treat the patient with hypertension? What are the benefits? By treating the patient with hypertension, we can reduce the stroke incidence by 35 to 40%, myocardial infarction by 20 to 25%, heart failure by 50%. So when you are treating stage 1 hypertension, an additional cardiovascular risk factor, a sustained 12 millimeter mercury reduction in systolic blood pressure over 10 years will prevent one death for every 11 patients treated. So you can achieve significant benefit. Prehypertension signals the need for increased education to reduce blood pressure in old to prevent hypertension. So when you are identifying the prehypertensive patient like a pre-diabetic patient, you have to educate to prevent development of high blood pressure. BB reduction as little as 2 millimeter mercury can reduce the cardiovascular event by 10%. You can see here 2 millimeter reduction of blood pressure according to the meta-analysis of 61 prospective observational studies. 1 million adults were there. By 2 millimeter reduction, you can reduce 7% reduction of risk of ischemic heart disease and 10% reduction risk of stroke mortality. So it is important to identify, diagnose high blood pressure properly and treat. So when you are approaching to patient with hypertension, we have to do patient evaluation. When you are evaluating patient with the documented hypertension, there are three objectives. First one is assess lifestyle and identify other cardiovascular risk factors or concomitant disorders that affect prognosis and guide treatment. Number two is revise identifiable causes of high blood pressure. Number three is assess the presence or absence of hypertension mediated organ damage. So this is the new term we use instead of target organ damage according to 2020 guidelines. What are the cardiovascular risk factors? We discussed this: hypertension, smoking, obesity, physical inactivity, dyslipidemia, diabetes, microalbuminuria or estimated GFR less than 60, age older than 55 for men, female 65 years, family history of premature cardiovascular disease, men under 55 or women under 65 if they had any family history of cardiovascular disease, that's a risk factor. So what are the identifiable causes for hypertension when you are evaluating patient? Look for these things: sleep apnea, drug-induced or related causes, chronic kidney disease, primary aldosteronism, renovascular disease, chronic steroid therapy and Cushing syndrome, pheochromocytoma, coarctation of aorta, thyroid and parathyroid disease. So when you come across a patient with a high blood pressure, when you are taking the taking the history, and when you are examining the patient or when you are taking the history also, always look for these secondary causes of hypertension to complete your history and identify the secondary causes of hypertension, which is very important, because if you treat these kind of secondary causes of hypertension, sometimes you can cure the high blood pressure. After taking the history and doing the examination, then you have to do some investigation for a patient with high blood pressure. These are the basic investigation you do for the high blood pressure patient: blood sugar, complete blood count, lipid profile, serum creatinine with EGFR, serum sodium, potassium, calcium, thyroid stimulating hormone, urine examination, ECG. Optional testing are echocardiogram, uric acid examination, urinary albumin to creatinine ratio. So this is one of my patient, young lady who presented with high blood pressure uh, at the age of 29 years, and then we did the ultrasound scanning. Then we found the absent or non-visualized kidney on the right side, Then we did the suspected some congenital malformation or some malfunctioning of the kidney, and we suspected whether there is a mild renal artery stenosis or angiodysplasia. Then we did the angiography study, and it shows absence of this renal artery. This is the aberrant renal artery. So that's why it is important to evaluate patient fully. And this patient was undergone the nephrectomy of this site. After that, her blood pressure was completely controlled. When you are treating a patient with high blood pressure, overview of treatment are we should have some goal of therapy, that is to achieve the target blood pressure control. We have to achieve the lifestyle modification, introduce the pharmacological treatment which is suitable for a patient, and you should have some idea about the algorithm for treating of high blood pressure. And after that, you have to have some idea about how to follow up the patient and what are the things you have to monitor during your follow up. When you are treating the hypertension, so there are two ways of treating patients with hypertension. One is a medical management, another one is a nutritional approach. First, we are going to discuss non-pharmacological intervention to control the hypertension based on 2017 ACC guidelines. According to 2017 ACC guidelines, weight loss is recommended to reduce blood pressure in adults with elevated blood pressure or hypertension who are overweight or obese. A heart healthy diet such as DASH diet, that is DASH stand for dietary approach to stop hypertension, that facilitate achieving a desirable weight, is recommended for adults with elevated blood pressure or hypertension. Sodium restriction is recommended for adults with elevated blood pressure or hypertension. The other non-pharmacological intervention is a potassium supplementation, preferably in dietary modification, is recommended for adults with elevated blood pressure or hypertension unless contraindicated by presence of CKD or use of drugs that reduce potassium excretion. Other non-pharmacological interventions are increased physical activity with structured exercise program is recommended for adults with elevated blood pressure or hypertension. And other thing is alcohol. Adult men and women with elevated blood pressure or hypertension who are currently consuming alcohol should be advised to drink no more than 2 and 1 standard drink per day respectively. What are the evidence to say these non-pharmacological interventions are beneficial in hypertension? Weight loss per se can reduce the blood pressure by 5 to 5 millimeter mercury. Healthy diet like DASH diet can reduce blood pressure by 11 millimeter mercury. Reduced intake of dietary sodium can reduce the blood pressure by 5 to 6 millimeter mercury. Enhanced intake of dietary potassium can reduce blood pressure by 6 to 5 millimeter mercury. Encouraging physical activity can reduce the blood pressure. Mainly aerobic exercises are recommended. By aerobic exercises can reduce blood pressure by 5 to 8 millimeter mercury. By dynamic resistant exercises can reduce blood pressure by 4 millimeter mercury. Isometric resistant exercise can reduce blood pressure by 5 millimeter mercury. How about alcohol? Moderation in alcohol intake can reduce the blood pressure by 4 millimeter mercury. So in summary, non-pharmaceutical treatment we can use to treat hypertension are like this. Avoid harmful habit like smoking, alcohol, reduce salt and high fat diet, lose weight if obese, regular exercise, follow the DASH diet. So sodium has a big effect on high blood pressure. What is the relationship between sodium and hypertension? It is seen strongly in patients with all patients and those with family history of hypertension, those with higher blood pressure at baseline, 30 to 50% hypertensive and 15 to 25% of non-tensive are salt sensitive. Salt sensitive more common in black race, obesity, advanced age, diabetic, renal dysfunction, use of cyclosporine. Those patients are more sensitive to salt and increase the blood pressure. And according to this graph, you can see this is the average daily salt intake. This is the blood pressure values, and you can see when the average the, the salt intake less, like Eskimos, their blood pressure is very low side, and Japanese, which is especially northern Japanese, they have they are taking high salt intake, and their blood pressure also tend to be higher side. Addition of sodium restriction to the DASH diet further reduce the blood pressure, systolic blood pressure by 3 mm mercury and diastolic blood pressure by 2 mm mercury. This reduction is associated with 17% of reduction in prevalence of hypertension and 6% reduction of coronary heart disease and 15% reduction in stroke and TIA. So you can see the very easy intervention, but you can get a very high or very large number of health benefit by reduction of the salt intake. Recommendations for the moderate salt restriction is for a hypertensive patient that includes 6 grams per salt or 100 milliequivalent or 2400 milligrams sodium daily. Salt is the issue because chloride ion with sodium raises the blood pressure. May normalize blood pressure in stage 1 hypertension if you just restrict the salt intake. Nowadays, people are very interested about food label, and when you are taking a food item, check the food label and see the content of the salt. And sodium free mean no salt when it is less than milligram per serving. Like that, there are values given for the food label. Other thing is alcohol and hypertension. 5 to 7% of hypertension is due to alcohol consumption. 3 drinks per day is the threshold for raising blood pressure associated with 3 mm mercury increase when you are taking 3 drinks per day. When you consider physical activity and hypertension, less active persons are 30 to 50% more likely to develop hypertension than active person. Medium to high levels of activity protective against the stroke according to the Framingham study. Walking per se reduces the blood pressure in adult by an average of 2%. In meta-analysis of 54 randomized trial, walking reduced blood pressure in average of 4 mm mercury irrespective of weight change. So how about potassium? In population studies, potassium intake and blood pressure are inversely related. In the diet, sodium potassium ratio is important. Sodium to potassium ratio of 1 to 1, a 3.4 mm mercury decrease in systolic blood pressure is predicted. High potassium intake is inversely related to the stroke incidence also. Other factors like magnesium, calcium role is not clear in hypertensive control. How about response to dietary treatment? Salt sensitive people respond well to salt restriction. Most respond to increased potassium in diet. 1 to 1 to 3.3 grams sodium is safe. 1.9 to 5.3 gram potassium is recommended to achieve ratio of sodium to potassium of 1, which is a goal. If taking a potassium wasting diuretic drug, increased potassium diet is essential. Next, come to the DASH diet. So DASH diet is the recommended diet in hypertensive patient. This is proven, and its benefit is assessed in various studies. It works in within 14 days time, lowers blood pressure quite well. It includes more potassium, calcium, and other nutrition. So there are dash diet plan, and a dash diet contain 78 whole grains, 4 to 5 vegetables, 4 to 5 fruits, 2 to 3 low fat to fat-free dairy products, 6 ounce or less meat, poultry or fish, 4 to 5 servings nuts, beans or legumes per week, 2 to 3 servings of fat, total calorie equal to 27% from the fat. So randomized feeding trial comparing effect of three dietary pattern control, high fruits and vegetable, and high fruits, vegetable and whole grain, low fat diet, that is a dash. So these randomized trials recommend compare the control group, high fruits vegetable group, and the dash group. Accordingly, DASH diet high in potassium, magnesium, calcium, fiber and low in fat, saturated fat and alcohol is there in the DASH diet group. According to this study, DASH diet significantly lowered the blood pressure in all groups, but especially in African Americans. In this graph, summarize the study. This is the control group. This is the uh, people who get fruits and vegetables, and this is the people who got DASH diet. This is the systolic blood pressure reduction. This is diastolic blood pressure reduction. So clearly you can see that there is a reduction of blood pressure when you are taking DASH diet. So dear students, we will continue the lecture soon. I will upload the next lecture to Moodle within few days time. Thank you.